Welcome back, all. For the second session for the day is chaired by Professor Preeti Tamani Ma'am, Assistant Professor, Department of Drug Regulatory Affairs, Poona College of Pharmacy, Bharati Vidyapeeth, deemed to be university. She has pursued her MS Pharm from Naipur, Mohali. She has academic experience of over 4 years and industrial experience of over 10 years. She has worked as a junior scientist at Dr. Reddy's laboratory. She has published 5 research papers and also 1 patent. I request ma'am to take over the platform.
Thank you. It is indeed my pleasure to introduce our next speaker for today, Mr. Syed Mohsin Khadri. He has done his bachelor's and master's in pharmacy from Rajiv Gandhi University of Health Sciences. He has been a drug information pharmacist in a drug information center in Karnataka State Pharmacy Council, Bangalore. He has worked as clinical pharmacist in infectious diseases unit, Rashid Hospital, and in a pharmacy department at Dubai Health Authority. He is currently working as pharmacist in SKMC Pharmacy, Abu Dhabi. Sir is involved in reporting and documentation of medication errors, providing dose medication administration aids, inventory management, patient counseling, and providing drug information to physicians, fellow healthcare professionals, and patients. Sir, with great pleasure, I invite you to kindly take over and start your talk for today. Sir, your mic is on mute.
Yeah, I didn't realize that. First of all, good morning, everyone. Thanks for that wonderful introduction. I always look forward for interacting the fellow professionals and share my experience with you all. So I take this opportunity to thank the organizing committee for inviting me to share my experience, especially Dr. Asavari, and she is my friend and senior from the same college, and Dr. Manjusha for coordinating with me as well. I would, with no more further ado, I can start my lecture. So I will start my screen sharing. Just one moment. Yeah, are you able to see my screen? Yeah. Okay, all right. So to the topic of my talk is, as you all know, medication safety in renal transplant services. And outline of my presentation will be like background of renal transplant and significance of medication safety in renal transplant patient, types of error which are in particularly occur in transplant patients, and clinical implications of these medication errors, and also what are the steps to avoid these medication errors. Now, to have a zest of my presentation, I want to give a brief background of why pharmacist involvement in renal transplant patients is a need of the hour. So as we are over a billion population country, and with a very high prevalence of diabetes and hypertension, and then which also contributes to the high prevalence of chronic kidney disease. Among all the CKD patients, at least 40 to 60% is due to diabetes, mellitus, and hypertension. And also, if the patient ends up in end-stage renal disease, the true burden is still unknown in India. There are multiple reasons for this. Usually, 90% of the patients die because of inability to afford the treatment, because dialysis is really an expensive affair, Now, to get visual representation, like this slide was taken from International Diabetes Federation, and in 2010 we had around 54 million people suffering from diabetes, and which is expected to rise in the coming years. It is estimated that by 2045, we will be having triple the present population suffering from diabetes, and more younger people are getting diagnosed of type 2 diabetes mellitus. So what exactly are the current trends in kidney transplantation in India? This is fairly older reference, like 5 years back. The prevalence of end-stage renal disease requiring transplantation in India is to be estimated to be in between 151 to 232 per million population. And then if an average of these figures are taken, then it is estimated that 220,000 people require kidney transplantation. Currently, approximately only 7,500 kidney transplantations are performed at 250 centers. So the numbers corresponds to only like 3% of the total people who require kidney transplantation. Then 90% of among all this transplantation, 90% come from living donors and 10% from deceased donors. Now, typical transplantations is like usually the patient is a typical transplant process. Usually the patients are referred from outside or other healthcare facilities to the transplant centers, and patient is accepted. Then patient is assessed by cardiologist, surgeon, vascular, and various parameters and immunology as well. Once it is decided with the donor, and then effective counseling is taken place with the help of transplant coordinators, then patient is activated and surgery is done, and discharge and chronic care follows. Now, why medication safety is very, very important? Because in general, medication errors increase mortality, morbidity, and financial burden. Medication errors are generally identified in almost all the areas of clinical practice or medical practice. Some of the causes which are not limited to like use of look-alike, sound-alike medications, high alert medications, and in some institutions, the weak institutional policies and procedures for medication safety, ineffective medication reconciliation methods, and then under-reporting of the near-miss events and unsafe practices. So reporting of near-miss events are very, very important, because if you don't report near-miss events, the policies cannot be strengthened. And if policies cannot be strengthened, sometimes the sentinel events or medication error with great magnitude usually occurs. And the positive side of this is most of them are preventable. Now, this was a study published from Department of Pharmacology, JIPMER, Pondicherry, decreasing medication errors in 4 intensive care units of tertiary care hospital. The intensive care unit, this was a prospective interventional studies, and then it was conducted in cardiology, medicine, pediatric, and neonatology. Baseline medication errors are detected by prescription order review and direct observation of administration of medication for 30 days. Now, to highlight this one, it's only addressed to only 2 aspects. One is prescribing aspects, one is administration aspects. The transcribing aspects are not done, the dispensing aspect are not studied in the studies. But still, if you look at the prevalence of medication errors, the numbers are staggering. 304 per 1,000 patient observation days, which is a very, very, very significant number. So prescription errors were the commonest type of errors, and followed by administration errors. So once they were the intervention group, the number of overall number of prescription with errors was reduced to 9.1% from to 3.5%, and there was no medication error reporting using that tool. So why medication safety in transplant patients is very, very, very important. Now, 10 to 12 medications on an average in chronic care of transplant patients. Usually, whenever the patient gets transplanted, he had somewhere before end-stage renal disease, which is secondary to other comorbidities as well. So already the patient has the pre-existing medications. In addition, after transplant, they will have another 5 to 6 medications. The usually corresponds the immunosuppressants, and as well as the antibiotics used for prophylaxis of opportunistic infections. So sometimes the patient on an average have 10 to 12 medications, and in some patients even the number is greater. Majority of drugs have very narrow therapeutic index, like cyanide, calcineurin inhibitors like tacrolimus, cyclosporin. Usually when they have like beyond the levels, desired levels, they can have easily toxicity, either blood, they themselves are nephrotoxic medications, and they increases the sugar. And also the most obvious side effects with tacrolimus is tremors. So patient will not be comfortable in taking that one. And that is life-saving medications in transplant patients. And now patients also have a comorbidities, diabetes, mellitus, and hypertension. So they will be taking pre-existing medications. And among all the 15% of the medication develop diabetes after transplant, which is secondary to steroids and CNIs. Always this population is vulnerable for opportunistic infection. So they have to attain a sweet spot between not having opportunistic infection and also not having a rejection for the allograft. Now, usually when the transplant patients following 1 or 2 months or within 6 months, they have frequent changes in their treatment plan depending on their response and the spectrum of side effects. Medication adherence can sometimes become very difficult and challenging because the patients will be having overwhelming number of medications, and it's very difficult for them to adhere to the agreed treatment protocol. The thing is, if medication error occurs in this set of population, it also increases mortality, morbidity, and financial burden to the patient and also to the institution, if institution is in the payer. But unfortunately, in India, the institutions won't pay for the patients. Usually, the patient comes at self-pay or in lesser set of population as an insurance pay. Transplant is an expensive affair, and chronic care of this transplant patient is also an expensive affair. So medication errors should not be, it can be very detrimental on the patient quality of life and financial burden as well. It can cause the loss of functioning graft, thereby affecting the quality of life if the patient ends up in dialysis. And usually the patient, once he had transplant, and no one wants to go back to the dialysis. Now, the good side is that the positive side of these medication errors is most of them are preventable. Now, commonest type of errors in transplant patients are incorrect dose, and the immunosuppressants share a large percentage of that one. And in some patients, if the patients are not educated about the treatment, they discontinue the treatment without any medical advice. And we have seen patients in our center that some patients was newly developed diabetes, and he stopped insulin or antihypertensive therapy. They think that it has to be taken for a set duration and then they can stop after that. And the patient ended up in readmission and not starting a new medication. Usually newly transplant patients have the like often or frequent changes in the treatment protocols, and the physicians play around the antihypertensives, because whenever a new graft is transplanted, in some patients the hypertension gets really difficult to control. Now, some of the factors of these kind of medications are patient specific, and patient specific errors are usually due to inadherence with the treatment protocols. Now, there was a study published in American Journal of Transplantation in 2007. It showed the spectrum of medication errors in lung transplant patients. I have included this slide because renal transplant medication is not very much different from lung transplant patients. So this is like if you look at the slides, the major kind of errors is like regarding the antibiotics in wrong dosages for infection prophylaxis, followed by magnesium. Magnesium is very important in transplantation because the immunosuppressants like CNIs can cause leakage of magnesium. And these patients are more prone for hypomagnesemia, which is eventually translated as hypokalemia as well. So potassium and magnesium, they tend to lose at more rate. So you have to check the electrolyte in these patients. The thing is, if there is no effective counseling, the patient end up in readmission to the hospital. Now, medication, there was also a study published for transplant patient in India. So this was from Department of Nephrology Institute of the Postgraduate Institute, Calcutta. When they analyzed, there were two sites which were included in this, government and as well as private side. And then the reasons they tried to identify for individual drugs. So most of them were like financial constraints in case of government institutes, and in private institutes where finance was not the option, forgetfulness and lack of knowledge of the medications. So these things can be addressed very easily by integration of pharmacy services in transplant. Financial constraints, yes, this is one of the genuine problem faced by so many patients. And forgetfulness, because they will be having like 10 to 15 medications. It's very difficult to remember the all medications. So transplant, as we in our hospital work closely with patients, physicians, and as well as transplant coordinators to make them understand what are the role of medications are and how they have to address that. Now, if you look at the medication errors and adverse drug events in transplant, the clinical comparison of like the patients without medication related problems and patient with medication related problems. So acute rejection rate was way higher in the patients which having medication related problems. And also it affects the readmission rates with 7 days and 14 days to 30 days readmissions. Then what is the potential impact of transplant pharmacies on development of medication related problems? So the thing is the admission rate for these admission reconciliation was done by pharmacists, and then the medication related problems dropped drastically. And there, as you can see, the p-value, this results does not signify the statistical significance, but yes, these kind of errors will be usually clinical significance. So now, what is the effect of these medication errors on graft survivals in 1 year of time? So if the patients have medication related problems, that's not good news for their graft survival. Usually it is like 0.75% of the initial at the time of transplantation. So we as a pharmacist have to be integrated into the transplant services and address the medication related problems and make sure the patient do not have them, which definitely affects the graft survival. So now patient-induced medication errors and associated ADs are very common in kidney transplant patients. And then these are general and transplant-specific risk factors associated with the development of these MRPs, and these are associated with increased risk of rejection and graft loss. And no one wants to go back to the dialysis. Now, if you come with the clinical and economic outcomes associated with medication errors, so two things I want to highlight here, like length of stay. So length of stay is increased if you don't have the pharmacist or address the medication related problems. And patient survival at the end of the populations in non-CSME group is 95%. So this is very, very important, and the cost will be staggering if no one address to the MRPs or medication errors or medication safety in this set of population. Now, if you look at the frequency of medication errors by drug class, again, I must say that immunosuppressant tops the chart, which is directly affecting the rejection of the graft. And some patients, if the doses of antibiotics are not addressed properly, they can get opportunistic infections like CMV disease and as well as PCP pneumonias. Now, if you look again, it affects the graft survival. And the patients may have the acute episodes of acute rejection in the patients who have the medication errors or medication related problems. Now, what is the pharmacist's contribution to transplant services on length of stay? This was the study published in American Journal of Health System Pharmacy, which said that if you involve a pharmacist in transplant team, the length of stay of the medication was drastically reduced from 7.8 to 2000 to 3.4 days. So why these errors? So if you look at all the studies, they highlight that immunosuppression as the class of drugs which contributes to the major errors and why this happens. And our sentence is not different from this. Tacrolimus, usually it happens with tacrolimus and MTOR antagonists like everolimus as well. Now, tacrolimus exists in more than one strength. It also exists in sustained release and immediate release. Sustained release is once daily formulation and immediate release is twice daily formulation. Now, errors are more common when given in 10 times strength or where in the hospital 10 times strengths are available. For instance, if the patient is prescribed 5 milligram of tacrolimus immediate release, and if you have 0.5, there are chances you can make mistake. And also existing in injectable forms also. Then incorrect manufacturer labeling, sometimes it happens in one study where the reference is mentioned below of the slide. Then the outer box was having the sustained release label, and inside the medication was immediate release medication. Now, in this type of in this study, they have quoted that one patient was dispensed tamsulosin instead of tacrolimus. And then one patient also was dispensed finasteride, which is known by Proscar, brand name, the leading brand, instead of tacrolimus Prograf. So, and errors due to, and the sampling time is one more error which can happen. For example, whenever a patient comes to the clinic, they have to do their the immunosuppressant levels. So we are involved in the patient. Sometimes if we have seen levels, usually in chronic care, it is maintained between 6 and 8 nanogram per ml. So if the patient is having 11, 12 or 15 and patient is stable, then we have to check with the labs when the sample was given, and we have to check with the patient that what was the time since the last dose. Usually some patients, out of a lack of knowledge, they take this tacrolimus and give their blood samples after 1 or 2 hours, which gives us erroneous reading. Usually the protocol say that it should be 12 hours past the last dose, and just beginning of the next dose, before half an hour, you have to give your blood sample. And non-compliance due to adverse effects are also one of the important problem, and the patients don't inform the physicians. With tacrolimus, we see it as tremors, and some patients have fine tremors and they don't inform. There have been cases reported that patients have stopped taking tacrolimus without informing the physicians, and within few days they get admitted into the hospital. Now, how to avoid these errors? Very effective patient counseling can prevent these errors, and at the time of discharge, the patient has to be explained what happens if they stop taking these medications or change the dose or change the timing without informing or without medical device or medical advice, and without informing the physicians. So now, how to prevent these errors? Now, actually, there was a study published, a pharmacist-driven intervention designed to improve medication accuracy in the outpatient kidney transplant services. Now, this was a phase 1 where no pharmacist was involved, and phase 2, the pharmacist was involved. The major kind of error occurs usually at the transition of care. For instance, if the patient gets admitted to the hospital, so transition of care is from ambulatory inpatient, and the patients after post surgery, they go into ICU. Again, there is a transition of care, and from ICU to stay the general ward, again there is a transition of care, and again from general ward to discharge, again it's a transition of care. So if there is no adequate medication reconciliation, these errors occur. And usually in most of the hospitals, we don't have computerized order entry system. So the next treating physician will not be knowing that what the patient was taking in a previous ward or facility. So pharmacist can play an important role, and he can be a joining link between this transition of care. Now, discharge medication reconciliation. Very important, because at the time of discharge, usually in teaching hospital, we see that interns or junior doctors write the discharge prescriptions. So sometimes, these main medications get omitted from the prescription or dropped from the prescriptions. Very, very important. And pharmacists can play, again, a very, very important role And in this study, there was like, it was before intervention, there was no discharge medication errors avoided, whereas in prospective studies where the pharmacist was involved, there were a great number of medication errors avoided. So now again, with the classification of drug medication discharge is like immunosuppression and prophylaxis, very, very important for prophylaxis. Usually the immunosuppressed patients are more prone for opportunistic infection. For example, CMV. There was a case report published in which for CMV prophylaxis, they give valganciclovir is the drug of choice, and they gave 900 milligram daily. So in the kidney transplant patient, the new graft don't function to its 100% just after the surgery. And then slowly the urine output the patient gains slowly the urinary output, and the creatinine clearance changes. So you have to always calculate creatinine clearance. And in this particular report, they calculated the creatinine clearance using MDRD equation, which means they readjust the dose for valganciclovir to 450 milligram. However, the patient was gaining full renal functions, and in the following days, his creatinine clearance significantly improved. But the patient continued to take 450 milligram for CMV, which is not enough as per creatinine clearance, and patient developed the CMV disease, and he was ended up into the hospital. So always make sure you calculate recalibrate the doses of the medications depending on creatinine clearance and functions of the new and functionality of the new graft. And pharmacists have to be involved in this more oftenly. Now, classification of discharge medication as the severity was like serious adverse drug, serious discharge medication error were encountered in retrospective analysis was 15, when compared to prospective it was only n. It was only 8, so it was addressed in ample time. Now, transplant patients are very vulnerable for medication errors, and pharmacist-driven discharge medication reconciliation increases medication safety by preventing the medication error significantly. Now, there are some of the technology-driven steps which can be used using informatics like mobile health platforms. Many apps are available which provides like a pill reminder and monitor your blood pressures like that. So the hospitals can come up with this development of mobile health apps, which can be integrated into the hospital software systems. Usually the advanced center, not all the centers have this one, but this is a very good method to employ. And then the modalities is that it can be integrated into hospitals, the software, and where physicians can have easy access to the electronic health record of the patient, and he can monitor the compliance and adherence and what are the side effects experienced by the patients. These are the steps which can be harnessed and which can be utilized, and which can increase the graft survival of these patients and improve quality of life. Now, there was a study published in Korea, where they have like use of information and communication technology. It was a randomized controlled trial. And usually what happened due to high baseline adherence, the ICT-based central monitoring system did not maximize medication adherence, because already the patients were aware of their transplant program, and they have well organized pharmacy involvement. But however, the patients were highly satisfied with the systems. And usually, if not all, at least if someone is doing clinical trials, they can employ this approach. Now, the thing, impact of pharmacist-led post-transplant medication management for kidney transplant recipients. It also had like most of the medical fraternity welcomes the involvement of pharmacists. According to the study, there was like most of the interventions were accepted by the for the medical team whenever the pharmacist approached them with the intervention. And also it significantly brought down the cost of the treatment. Now, cost is very, very important because of the cost, the patient may be inadherent and all the transplant program gets compromised. So very important to also look at the pharmacoeconomic aspects. And then there is one, this is the approach what we employ in our hospitals, providing dose administration aids. Like these are the blister packs what we prepare for our transplant. Not all the transplant patients are enrolled in this program. uh, there is a set criteria for us to enroll this. If the patient is getting repeatedly admitted in the hospitals, despite repeated effective counseling, they don't understand their medications. And some of the patients are, one of our patients is schizophrenic, so he cannot remember the medications. And some of the patients in transplant, they are already having diabetic nephropathy, retinopathy, and they are partially blind. So in such cases, these really help them to be stable. And once the patient is enrolled into once the physician sends a requisition for us to enroll the patient in this program, we sit with the patient and interview with him, and we also assess that whether the patient is able to remember the medications or not. And the patient will also be provided with a medication aid sheet, which provides when what is the medication to be taken at what time. So if such patients come to the clinic, the physicians coordinate with us if there are any changes in the medications. And our patients are, they know very well that if they are taking even paracetamol from some facility, they have to inform us. So usually the technicians fill these packs. This is the packs. One pack holds good for 1 week. These are weekly packs, and there are 4 columns, and the medications are entered by the technicians. And then once the physician confirms that there are no changes, or whatever the changes, we make amendments and close the packs. So the patient is provided the blister packs or the dose administration is till the next appointment, so as to encourage him not to miss the scheduled appointment. Sometimes what happens if the patient may be given more of these packs, then they don't come to the appointment, so we don't give the packs. We just give till the next appointment. Then once it's sealed, it looks like this. So that just the patient has to take the medications, and they have to consume it. The thing is, some of the medications which cannot be put in these packs are effervescent medications, or the medications which change color exposed over a period of time. And also the only one thing what we have to make sure that the patient deliberately is not adherent. So such patients cannot be helped. And then the disadvantage of this is when they break and with poor visibility, with poor eyesight, some medications are dropped from the on the floor, and the patient will not have idea. So these things have to be addressed, and sit along with the patients and ask them that these many tablets you have to take in this time of particular day. Usually the caregivers play an important role, and patient attendance in the home. So but my final thoughts are like transplant patients are more prone for medication errors. Medication errors can directly affect the graft survival and quality of life of the patient. Effective and timely intervention significantly reduce the financial burden. And then pharmacist participation on transplant program reduces the significant number of medication errors, and innovative methods like utilization of smart apps can be used to improve medication adherence, and unified electronic medical record can be employed. Usually this is still a distant dream in India. And then by this, I finish my presentation. The topic is held open for discussion.
Thank you very much, sir, for a very informative and insightful talk. Uh, in brief, I would like to just summarize the points that we could gather from your talk. You have discussed regarding kidney transplantation and the background to start with, and then moved on to the importance of medication safety in general and specifically in transplant patients. Then the common types of medication errors in transplant patients, clinical and economic outcomes associated with these errors, and then very importantly the methods of preventing these types of errors and especially the role of pharmacist in this, and then various types of dose administration aids, smart apps which could help in the prevention of medication errors. So with this brief summary, I would like to invite the audience to ask any questions if they have. Sir, I have one question.
Yeah, please go ahead.
So, although not directly related to this, we know that in case of cardiac stents which are implanted, they have tacrolimus or immunosuppressants which are there. And is there any impact of medication errors related to such kind of cardiac related therapies which may impact on the kidneys or does it have any correlation?
No, actually, the cardiac errors are entirely different. Tacrolimus eluded or everolimus, it does not have any errors. The thing what in cardiac post stenting or PCI, the main errors are like continuation of dual antiplatelets. The thing what happens, like if the patient in India, it's surprising for me whenever I go and see the formulations, most of them are combination drugs. So like clopidogrel 75 milligram will be with aspirin 100 milligram, with aspirin 75, which will be aspirin 325. So the thing is, what happens usually as per the guidelines, it should be 6 months. And in drug eluting stent, it should be 9 months. It should be the dual antiplatelets, it should be continued. But the problem with us that it is usually it's continued indefinitely.
Okay.
Yeah, indefinitely. And there are many patients will end up into the hospital post intracranial bleed. The one of the most important factor, which is unique to Indian set of population, that here the patients don't stick to one physician. They go and play around to so many physicians. So the next physicians will not know what's going on with the patients. This is very important. And sometimes, finances are the driven factor for medication inadherence. The patient come to the doctors, and if they find the consultations fees high, then they go for GPs or medical practitioners who don't have any specializations. And without medical supervisions, they stop these medications, which are very detrimental, So these are unique challenges with our population.
Thank you, sir. I have some questions from the audience. I will read it out. What is the role of technology or informatics in the medication safety monitoring in renal transplant patients?
Yeah, the thing is, we have here in our hospital like electronic medical records, So we work. We have like four main hospitals and multiple primary health centers, which are under the umbrella of Abu Dhabi Health Services Company, which we use the single software which is known as Cerner. And then any physicians log into the system, they can have an access of all the electronic medical records. It does not happen in India, unfortunately. So what's going on with the patients, no one knows here. So if at least the leading hospital then can come up with electronic medical record system, it will be very beneficial for the physician as well as the patients and all the allied healthcare system to monitor what it is going on with the patient. So that's how we can avoid the medication errors.
Okay, thank you, sir. Any other person from the audience would like to ask a question? Sir, there is one question from Mr. Chinmay. He is asking, immunosuppressant drugs are given after transplant to prevent rejection. If new kidney is rejected, how the rejection is prevented later?
Yeah. The thing is, rejections, whenever the surgeon declamps the graft, at the time of surgery, two things happen. The blood from the donator organ enters the systemic circulation, and the recipient blood goes to back in the newly graft. So the rejections are divided into three: hyperacute, acute, and chronic rejections. So hyperacute rejections, you cannot do anything. It happens due to insufficient immunosuppression just before the transplant surgery. I do not want to get into details of that. And then acute rejection is due to cell mediated or antibody mediated, depending on that. And usually these immunosuppressants are also nephrotoxic agents. So you have to differentiate between whether the rise in serum creatinine due to actual rejection or due to calcineurin inhibitors like CNS, tacrolimus and all. So they do the biopsy, and after doing biopsy, if they find the sclerosis of the kidney, then it is due to CNI. Then they will remove CNI from the medication regimen, and they will add up to a new class. If they have the antibody mediated or cell mediated rejection, then go for pulse therapy of IV cortisones, which is usually by methylprednisolone and other immunosuppressants like rituximab, like that. So depending on the what kind of rejection the patient suffers, the treatment modality changes.
Sir, is there any intervention in drug therapy for renal transplantation?
Yeah, there are plenty. If a pharmacist involvement, there are plenty. The reason why what happens, like for example, there are chances of the medication errors in usually the dosages. This is the most significant medication error. Some patients have error in sampling time. They come to the clinic with high levels of immunosuppressants. The physicians looking at the levels, they tend to reduce the medications. So you have to ascertain whether the sampling time is correct. There are many ways where a pharmacist can play a really important role in digging out whether the patient in adherence or whether he is having any side effects. So depending on that, he can make interventions accordingly.
Thank you very much, sir, for clearing all our doubts. Uh, there is one more last question which I will take up. If both kidney fails completely, does it produce urine and any changes are observed?
Yeah, this is like most obvious questions when some patient comes with a renal failure. Whenever you disclose this information to a patient, they say that one kidney is failed or two kidneys are failed. It is not one kidney fail. It is always a two kidney fail. The reason why, if any case, if some one kidney is failing, the other kidney takes up hypertrophied and they take up their role. And unless the urine output goes minimum, the patient will not realize that one kidney is failed. So eventually, when both kidneys are failed, then the symptoms starts to kick in, and then the patient realize that his kidney something is going wrong, and when they check this, they find that kidneys are not working. It is the basic question asked by any kidney failure patient, that one kidney is failed or both the kidneys fail. It's always both kidneys fail.
Thank you very much, sir, for your very insightful talk. And on behalf of Poona College of Pharmacy, Bharati Vidyapeeth deemed to be university, I would like to thank you for your time
Thank you very much. My
and
pleasure.
for joining us from Abu Dhabi and enlightening us on this topic, which is so relevant, especially in the Indian scenario, where a large amount of population is suffering from renal related disorders, which are actually an outcome of either hypertension or diabetes. So thank you very much once
Thank
again,
you
sir,
very much.
for your
Thank
time.
you very much. Thank you.
Thank you, sir, for accepting our invitation. I would like everyone to kindly turn on their videos for a photo. The morning sessions are done. I request everyone to be back by 1:45 for the afternoon sessions.